Yeah, thanks for inviting me here. My name's Taz. I'm the founder and CEO of DocAbode. Came to Leeds Med School in the late 90s, kind of hung around, became a GP, and been in West Yorkshire for the last 20 years. I've got another role. I'm the CCIO for the Health and Care Partnership in Bradford and Craven there. But actually, big shout out to Nev, because it was Nev and Richard Stubbs, the CEO of the Academic Health Science Network, that I went to with this sort of crazy idea almost 10 years ago. And they gave me this opportunity through their proof of concept program. And I think you call it Propel now. And really has, that opened up funding and opportunities, evaluations, and that evidence base that Nev, keeps talking about. And also a massive shout out to BGSS, because as part of my journey, I can't write a piece of code if, my life depended on it. But they were the organisation that took us from a sort of something a developer built in his sort of room to an enterprise level scalable solution that was all cloud hosted. And they actually helped me to recruit back in, years ago, my very first developer as part of DocAbode. So they're an amazing organisation. But I'm here to talk about virtual wards and specifically workforce scheduling. The quickest way I can tell you, I was telling Michael earlier about DocAbode, our use case when I first started DocAbode was in urgent care. But if you can think of the love child of Uber and Deliveroo and Match.com, so all of those is sort of how DocAbode functionality works. But I'm going to try and relate all of that in sort of dynamic workforce scheduling around virtual wards. So I've actually, Pad said I'm never going to get through these slides in 10 minutes, so I'm going to race through the important ones. But I think it's important, here's an NHS slide about what exactly is a virtual ward, because I guarantee you, everyone probably thinks something different. Usually people think it's remote monitoring. Actually, it's much more than that. It's around that hospital, someone mentioned it before, can you get a hospital bed in someone's place of residence, wherever that may be? And actually that is a whole pathway change. And actually specifically, this is a sort of an integrated care system, again, another NHS slide that most people are familiar with, but it's around how do we integrate that level 4, these are probably pre-medically optimized patients from the hospital into a community setting. And importantly, it's around this hospital at home. So the way I will explain this particular slide, this is my own creation, but the writing is all the guidance for the ICS, the Integrated Care System. And I see virtual wards as a big Venn diagram of where hybrid working, where remote and face-to-face come together. And as I think Michael said earlier, face-to-face is very resource intensive. That's the last thing that you want to do, to send someone out there. But it's appropriate for when you've exhausted as many remote means as possible to manage that patient. So it's a whole pathway of care around virtual wards, working with urgent community response, hospital at home, even same-day emergency care. These are all parts of one system, and it's really exciting to hear that in West Yorkshire, they're bringing all these into one big area where there's one remote monitoring system, not 10. And I'm going to break Nev's rule, because Nev introduced me to UCL Partners in London, and we ended up winning, in fact, the biggest community trust in the country, which is Central North West London. NHS Foundation Trust as a customer in the peak of the pandemic, and we've had the support from their AHSN in evaluations, deployments, that sort of thing. So that has worked quite well, Nev, going down south for us. But really, so really, it's this bit that's been touched on your left, which is around this opportunity around a flexible, multidisciplinary team, regardless of which organisation you're working for, being able to meet the needs of that patient. So knowing what that patient needs in that particular time, where your staff are, working across those organisational boundaries as one fluid workforce. And that's exactly was my vision right from the start with DocAbode. How do we get clinicians to work flexibly on terms that we can work on that isn't going to create burnout, reduce all the inefficiencies with administration, and get more direct clinical care time with patients. And how do you do that working across organisational boundaries? So I am going to rattle through some of these things, but the common denominator and theme in all of this, and again, several of the speakers have talked about this in the past, is workforce. There's enough money out there, you're not going to get, there isn't a queue and thousands of doctors and nurses waiting to see all this activity. It's been said before, but our hypothesis when we got commissioned by North Central London ICS to go in and work out what were the workforce challenges, and specifically around the scheduling of that workforce in relation to virtual wards. And we did that over the last 12 months. And I'm going to show you some of the stuff. This normally takes an hour, so I will rattle through it. But it's the recruitment, retention, it's around the governance, the handoffs, the clinical safety in all these pathways, and the sustainability. How do you create a sustainable workforce model when we just don't have enough of the workforce available? So we had this hypothesis, and you'll see, you might not be able to read this, but at the top, this was, I think, 27, so all the providers of North Central London who manage virtual wards and UCR pathways. This was the ICS asking them what are you most worried about in relation to virtual ward ambition? They didn't say the technology. It was about the workforce, staffing. These are the sort of the major areas that they came up with. So we went in addressing what needs to change around workforce scheduling. Now, workforce scheduling is a big area. We focus on real-time dynamic scheduling, knowing exactly who's available. So we need to speak to the electronic patient record, the rostering systems. If I get to it, there's a slide in the end all about interoperability. But it's around how do you create that sustainable model of care for virtual wards. So we created, in conjunction with a really great consultancy they call Morehouse down in London, and we did this work, they call it a double diamond. So we did a whole load of discovery work, understanding the needs across providers and the ICS. We defined sort of the core themes of what these issues were. We ideated in workshops to try and work out what this problem was, and then we designed a future state with all the providers to create this roadmap. This is where I am going to kind of have to shoot through, but 5 major themes emerged around creation of the schedule, teams communication, the interoperability, we've touched on that many times, tracking, utilization of the workforce, and actually staff satisfaction. How can you get more out of the workforce without worsening burnout? So we did this and we brought this to life through various personas, because we spoke to from execs, ops, frontline, technology providers, and actually there's a lot of work behind all this, but we spoke to these sort of key people around the senior managers of the Trust Virtual Ward, members of the schedule and rostering team. How do you get the right person, whether it's the triaging down to face-to-face? How do you get today's problem that's tomorrow's emergency into the workflow of those particular community staff? And we, of course, wanted to find out more from the community teams, what was sort of holding them back. We did all of this, but I just want to draw your attention in terms of all the workshops and designs, but these are the sort of the principles around virtual wards and scheduling, and it's around being interoperable with existing systems. And that's not just the remote monitoring, EPRs, like I said, there's a slide at the end that I can go through, but it needs to be integrated with future digital solutions. What Nev was saying around failing fast, tons of new stuff is coming in. In COVID, it kind of exploded, but now there's a bit of a consolidation of all these tools. What's worked well are being amplified. Automated intuitive scheduling, live communication, understanding patient requirements in real time. How do you know that patient that's been discharged into, say, an urgent community response team, what that requirement is, who's a member of staff that's available, are they nearby, if they need to set up an IV? I think it might have been James was talking about some of the pathways in Leeds that they're setting up. Reporting, auditability, a lot of the BI associated with that, and then just the resource management that supports cross-boundary working. This is a slide, it's probably very small and you can't see, but there's a lot for this to be successful, you've got a lot of interoperability here. And obviously we've got kind of 6B in the room who are experts in this. It is really challenging as a small provider to kind of get hold of the data. And actually sometimes you need some big trust behind you to be able to get APIs from some of the big sort of duopolies that are around. But actually, it took us about 7 years to get an API, and we finally got it. But you've got to have systems and processes in place that can allow that seamless transfer of information to do that. And actually, this is my last slide, I promise you. Our approach, we are like 10% of it. The technology platform up there, and this is just the North Central London partners who we worked with, is just one aspect of that. This is massively a transformation piece. You cannot do this without an amazing sort of change and transformation team. And that can come from HSN, so people like UCLP down there, the Health Innovation Network now in Yorkshire Number, but actually the BI, the data insights, project management, evaluation, every deployment, we actually get sort of handshaked with the HSN from Nev and the team. And we make sure we've got a health economic and a real world impact assessment for every deployment that we do, because there is a massive hierarchy of evidence that you need to show that there is a return on investment. If you're not saving money, or you're not dealing with a backlog, or you're not dealing with a workforce, no one's interested. So you need evidence to deal with all those things. And from my personal point of view, it's around ensuring a sustainable workforce. We're not burning everyone out, but how do you make things more efficient? How do you do things more with what you've already got? And so we now have the evidence that we have actually doubled the productivity just by using our scheduling. And I can go into all the detail, probably for another day, how we do that. But I just wanted to thank you. I think I've kept roughly within 10 minutes for listening, and please come and ask me questions.